In this anatomic cutout, the stomach and small bowel are seen in their normal anatomic position. A gastroscope is inserted into the stomach and through the pylorus. A guide wire is then placed down the working channel of the gastroscope and directed into the duodenal bulb. The delivery capsule is then threaded over the guide wire into position within the duodenal bulb, transversing the pylorus. The guide wire is removed and the gastroscope is reinserted to confirm appropriate position of the delivery capsule. Utilizing continuous dynamic fluoroscopy, the liner and atraumatic ball are advanced 2 feet into the proximal small bowel. The atraumatic ball is released within the lumen of the small bowel and allowed to pass on its own. Finally, the nitinol anchor is deployed into the duodenal bulb, self-expanding to tether its anchor mechanism into muscularis tissue. The liner is flushed with dilute contrast to ensure patency. The gastroscope and delivery device are then removed and placement is complete. The endobarrier is now open and patent, where chyme is passing through the lumen and excluded from bile acids and secretions. With peristalsis, the chyme will transit the length of the endobarrier until exposed to the small intestine again at the proximal jejunum. When the endobarrier is removed, a gastroscope is placed down the esophagus and into the stomach and enters the duodenal bulb. A hook grasper engages one of the 2 drawstrings. Pulling back on the drawstring allows for collapse of the anchor struts, and the now hooded anchor, liner, and gastroscope are removed as one, slowly and atraumatically, first from the stomach and then from the esophagus.